everyone. Thank you for joining us today for the pre-application webinar on approaches to identify and care for individuals with inherited cancer syndrome webinar. Before passing the presentation over to our speakers, I'd like to provide a few tips for using WebEx so that you get the most out of today's webinar. All attendees will be in listen mode only. Please feel free to submit your questions throughout the presentation in the Q&A panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. If you need to view live captioning, please refer to the Media Viewer panel. I wanted to note that today's webinar is being recorded. We also have a feedback survey. Please take a moment to complete that at the end of today's webinar. With that, I will pass the presentation over to our speaker, Dr. Erica Braslau.
Hello, everybody, and welcome. I want to introduce and anchor you as to where we are. We are at the National Cancer Institute, which is the leading federal agency that conducts cancer research. NCI, as you can see from this org chart, has 30 divisions, offices, and centers who work together to build, maintain, and enhance cohesive and comprehensive cancer research agenda. We have 2 intramural divisions as you move down the org chart, and we have 5 extramural divisions. I'm with the largest division, the Division of Cancer Control and Population Sciences. And we support cancer surveillance, epidemiology, health services, behavioral science, and cancer survivorship. This program announcement is being supported by 2 of the programs within the Division of Cancer Control and Population Sciences. Epidemiology Genetics Research Program, known as EGRP, where my colleague, Nani K. Shelburne, is located, and the Healthcare Delivery Research Program, HDRP, where I'm located. I'm now going to turn the webinar over to my colleague, Nani K. Shelburne.
Thank you, Erica, and thank you to everyone who joined us today. The RFA that we're speaking about today comes from our Blue Ribbon Panel recommendation to sponsor initiatives to improve the current state of genetic counseling and testing, prevention, early detection, and knowledge landscape for those with an inherited predisposition. The goals are to increase case ascertainment for proband and at-risk relatives, improved delivery of evidence-based services, including genetic counseling, preventive and early detection services, and ongoing surveillance. Inherited cancer susceptibility really applies to about 10% of all cancers, and we identify the susceptibility through genetic testing and counseling, which we know is underutilized. The cancers we're discussing are associated with multiple genetic syndromes. And we've seen genetic testing change over the past 2 decades, from single gene to multi-gene panel tests, and now tumor sequencing, but this has just increased the complexity. Our patients can have a cancer diagnosis and see their oncologist, or come in with a family history of cancer when they see their primary care physician. And this could lead to a referral for genetic counseling and potentially testing. There's a risk at this time point for loss to follow-up. But should they get to genetic counseling, they could have the family member with cancer contacted, there's consent to test, or potential for no testing. The results can be positive, negative, or have variants of unknown significance. But these test results, it's important that we communicate those both to the patient and to the family member, and also to their primary care physician or oncologist who's caring for them. There's a risk at this point also for loss of follow-up and that they don't receive the appropriate care. And we also have an issue with no family history with these patients. Sometimes they're adopted, they don't know their family history, or it's from a small family. So to address this process, the aims of this RFA include developing and testing strategies to increase case ascertainment of hereditary cancers through different approaches, develop, test, and adopt evidence-based healthcare delivery models for these hereditary cancer prevention and detection, test sustainable implementation strategies across healthcare settings and variety of populations, study the behavioral and psychosocial outcomes of counseling and testing on at-risk individuals and the impact on their follow-up care, and identify how the healthcare delivery approaches can be sustained. This RFA uses a U01 cooperative agreement mechanism, which is an assistance mechanism that will include NCI programmatic involvement. So each funded application would have 2 NCI program directors, one for administrative and one for scientific oversight. The NCI program directors would lead a steering committee that would also include investigators from funded applications. This would be a non-voting body, but the goal would be to share the challenges, the successes, and findings as we move through the grant. Please note that in the RFA and the budget, there is a request to include meeting travel funds into the application to come to Bethesda once a year. This RFA has one application due date, January 9th, 2018. NCI intends to commit $4 million total cost in FY 2018 to this RFA. It's an intention that this $4 million would be also committed over 5 years. This will fund up to 4 awards, and each application is limited to no more than 5 years. Each project needs to be specific in its length and its budget, and it has to be reflected in the proposed science. All applications need to be MultiPI, and the expertise needs to represent the scientific components of the proposal. So for an example, an application could include experts in epidemiology or implementation science or clinical scientists, along with experience in implementing programs and quality improvement. Foreign institutions and components are not eligible for any Moonshot funding specific to this RFA because the goal is to test U.S. models of care delivery. Again, foreign institutions are not eligible for funds or applications. For all Cancer Moonshot initiatives, we have a Cancer Moonshot public access strategy that requires data and resource sharing with existing NIH resources. So please note this in the RFA that every application must submit a public access and data sharing plan. And some examples of existing NIH resources are the Genomic Data Commons and the new Cancer Epidemiology Data Repository housed here at DCCPS. There are also review criteria that are specific to the Moonshot initiative in this RFA. Under significance, you'll see where reviewers will be looking for near-term translational potential of each application. And for the approach, again, they'll look for that public access strategy. They're going to see that they want to look for that there's adequate outcome measures included in the application and that human subject protection is also addressed. So some interest with this RFA are a variety of targets, including patients, providers, families, and healthcare systems, a variety of complementary approaches, including tumor-based testing and or family history-based ascertainment, looking across healthcare settings, including a small or solo or small group practice, a large group, or a tertiary care setting. And really want to look at diverse populations from urban and rural settings, across ages, across socioeconomic status, and minority and cultural groups. There's an interest in best practices for how we counsel and get informed consent and follow up with these patients, understanding the behavioral and psychosocial impact of the genetic testing, and what are the workforce needs to support good approaches. In the RFA, you'll see these 6 bullets that all applications must reply to. So all applications must develop, test, and adopt strategies to increase case ascertainment, improve evidence-based healthcare delivery for those with an inherited susceptibility to cancer, focus on multiple hereditary cancer syndromes, not just one, and include at least 2 different healthcare settings or population groups, compare more than one strategy, which may include usual care, and focus on the implementation and sustainability of interventions. We've received questions looking to define who are those with an inherited susceptibility to cancer, and this can include either or both patients with active cancer or a history of cancer, as well as at-risk individuals. And when we're looking at these subjects, we're looking at the totality of care from case ascertainment all the way through follow-up care. So an application only looking at ascertainment or follow-up care would not be applicable. When looking at the totality of care, again, you're looking at either or the cancer patient or at-risk individuals. When we discuss including at least 2 different healthcare settings or populations, we get questions about what we mean. The RFA goal is really demonstrate what methods work across various groups and healthcare settings, because we know that one size fits all is not going to work to get the desired case ascertainment and follow-up. So individual applications need to include at least 2 different healthcare settings or 2 different population groups. So some responsive examples would be utilizing an integrated healthcare setting that services multiple populations, which might include race, socioeconomic, or age, across multiple care settings. So maybe an academic center that has community sites as well. You could utilize a primary care network that includes several counties or states. You can compare strategies across pediatric and adult populations. You could compare strategies also across socioeconomic groups. The approach requires that you look at implementation and sustainability. So study findings should lead to sustainable implementation of care delivery models at study completion. We receive questions asking if you could include the development of a risk prediction tool through the application, and that would not be supported because at the end of the study you would not have something sustainable. For sustainability, the goal is to identify models across case ascertainment, testing, and follow-up care that are, again, sustainable. So you want to consider testing methods that potentially are attainable via insurance or nation, state, local, or private programs. And you might look at care models that are or will be sustained by the workforce that you currently have. If you feel it's necessary to include budget for genetic testing or workforce costs or other support in your grant, you need to consider justifying why the services cannot be covered otherwise, and focus on describing how service will be sustained after the grant is funded. Because as remember, for Moonshot initiatives, the reviewers will be looking for the near-term translational potential of your application. So I want to thank everyone for joining today. We have we're going to open it up for our Q&A feature, and the instructions are here on the page, and also we'll post a list of our frequently asked questions on the website. I will close with reminding everyone this is a Cancer Moonshot initiative with the goal being to accelerate cancer research. And the Blue Ribbon Panel specifically recommended demonstration projects. So I encourage you to be innovative with your applications, consider the reach of your strategies and the potential impact. So if you have any questions, please submit those, and we'll talk about a few as well. One question that we've got is letter of intent. In the RFA, it discusses that a letter of intent is due December 9th. These are not required, but they are encouraged. They will allow us to estimate the review workload and ensure optimal review for all the applications. I also want to reiterate funding, because we receive a lot of questions about funding. So again, it's total cost, $4 million in FY18 with up to 4 applications funded. This does not mean we will fund 4. We may fund 2. It may be 3. It really depends on the merit of the application and the budgets that come in. So again, your budget needs to reflect the science proposed. We'll also be selecting applications that use a variety of settings and populations. So we're not going to be selecting 3 applications that all potentially use large academic medical centers, for example. So I encourage you to consider a variety of settings.
One of the questions that's come in is, would a healthcare system that has both primary care clinics and hospitals count as 2 systems, or would it have to be 2 unique healthcare systems? The way we see it is both primary care clinics and hospitals would count as 2 healthcare systems. We're trying to have this focus predominantly within the community setting, so we encourage that individual healthcare systems that would cover that. Another question that just came in is it correct that a new investigator status is applicable if all of the multiple PIs are new investigator? so I'm just going to translate that. Yes, we need to have, if you're going to be a new PI, then both PIs need to be new. Otherwise, it doesn't benefit the one individual who is new and the other one who is more experienced.
Could you comment on the requirements, including the multiple PI and the multiple sites and systems? So one question we received similar to this is, does a PI, can all the PIs be from one system? Can they be from multiple systems? And again, the PIs need to represent the work that's being done and the expertise that's needed to manage the grant. So not specifically looking at where the multiple PIs are located, but looking at the expertise and their ability to coordinate the work across the sites that are involved.
Another question. Will consortia of institutions be allowed to apply as a consortia? And we agree with that, that consortia are able to apply for the funding announcement.
Received a question about, does the application need to cover both case ascertainment and follow-up care? Yes, as we've mentioned before, you must address case ascertainment through follow-up care for each application. Case ascertainment and follow-up are equally important to meet the intent of the Cancer Moonshot recommendation.
One question that I've just received is, given the focus of the multiple PI project that includes health systems, can you share any thoughts on what entity would be most appropriate as the prime agency? And the response is, the prime agency would depend on where the majority of the work is being carried out and the population and the level of comfort between the PI and the lead.
Will a project focusing on discovering new risk variants and genes without implementation plan and clinical practice be considered responsive to this RFA? The answer is no, it would not be responsive. This RFA is not looking to identify new variants, new genes, new risk prediction models. It's looking for the implementation and demonstration projects. There's been noted that there is an error in the RFA. It discusses the advisory council review is August 2008, but the earliest start date is July 18th. No, that start date is not correct. The council review is still expected to be in August or shortly after. Therefore, start dates will be after that.
Somebody just asked about sustainability within a system. Could the individual who asked that question please give us a little more information?
So there's a question regarding utilizing health systems with multiple hospitals, both including community and academic sites, and whether they'd be responsive. And yes, that would be responsive if you're addressing both care settings in an academic center and community settings. Someone's asking whether, for example, the genetic test must be done in a clinical lab or clinical setting. All genetic testing must be done in a CLIA-approved lab. Can new workforce be paid for by the grant in order to absorb increase in demand with the thought that these positions would be paid for within a system if program is successful? So yes, it can. Again, you need to justify why it needs to be paid for by the grant, and you need to really discuss about how it would be presented and how it would be sustained afterwards.
the question that I asked for more elaboration earlier is it required that the implementation of this project is sustainable beyond the length of the grant? And we're saying, yes, the whole point of doing this is not just to do a research project, but to keep this within the community further on.
So again, questions about whether the budget can include the genetic testing and personnel. So again, it can, but you need to talk about how it's going to be sustainable afterwards. For example, if you are paying for genetic testing through the grant and then the grant funding ends, how is that testing now going to continue to be paid for, or the cost of genetic counselors, or the cost of technology support that's included in your method? This method that you're testing needs to be included. So a question on, can funds be used to pay for genetic testing for individuals without insurance? Again, you could include it, but you need to justify how those individuals would then get testing after the grant funding is ended.
The comment we just got now is, can we comment on the metrics of sustainability? And in general, this will depend on individual study design and the population that's served, and how you are measuring the success of the program implementation and sustainability. So we're really putting this emphasis back on the PIs to come in and demonstrate to us how they would and how they would comment on the metrics themselves. And we would be very happy to have an individual conversation with you if you send us your specific aims.
So the question again on clarify why the development of a risk prediction tool would not be supported under this RFA. Again, this RFA is focused on the implementation side, not the development of new models.
Okay, a question about the budget has come in that so we would like to make some clarifications on the budget. First, the question is, one, are indirect costs included in the $1 million budget per application? First of all, it's not $1 million per application, and secondly, the indirect costs will be included within the total cost.
Question about is the use of telemedicine for things like genetic counseling, is this considered or allowed within this RFA? And yes, that would be a strategy that could be explored.
Another question, is it acceptable to evaluate cost-effectiveness of planned approaches as long as it's appropriately integrated into the science and approach? And our answer is affirmative, yes. We don't seem to have any more questions, but we do encourage you to reach out to Noni K. Shelburne and myself, Erica Breslau, and we also encourage you to send us your specific aims page, to send us your letter of intent, and we are both very happy to have individual and joint calls with you. And we're very thrilled you participated in today's webinar. Thank you very much.